ആരും തുടങ്ങുന്നില്ലേ?
Yes, sir. So can I start? Sir, am I audible? Sir, am I audible?
Yes, sir, audible. Sir,
Yes.
already asked to start.
Yes. Good morning, teachers and dear friends. I'll be presenting a short topic on surgical anatomy relevant for APR. Coming to the definition of rectum, there has been various discrepancies among defining the extent of rectum. Now, there is a considerable variation among definition between anatomist, endoscopist, radiologist, and surgeons. And as far as surgeons are concerned, the proximal limit, that is the rectosigmoid junction, is marked by the coalescence of the tinea coli, the loss of the appendices epiploicae, and the fusion of the surgical mesocolon. Now, this roughly corresponds to the level of sacral promontory, which is again approximately 15 centimeter from the anal verge. Now, regarding the distal limit also, there has been various confusions. And again, as for surgeons, the definition of distal limit, that is the anorectal junction, is formed by the puborectalis sling, which is in the distalmost rectum. Now, this is the longitudinal section of rectum, showing the interior aspect as well as the musculature. Now, here we can see that there are three valve-like projections into the lumen of the rectum known as the valves of Houston. Now, although these are named as valves, they do not produce any mechanical impediment to the flow of the contents of the rectum. The surgical importance of this valves of Houston is that after complete mobilization of the rectum, the valves of Houston disappears, and this produces an additional 3 to 5 centimeters of rectal length. Now, like any other part of the GIT, the rectum is also formed by an outer longitudinal and an inner circular muscle group. The circular muscle at the distalmost portion forms the internal anal sphincter, whereas the longitudinal muscles contribute to the external anal sphincters. Now, here we can see that, like I said, among anatomists, the distal limit of the rectum is defined as the dentate line. The dentate line is a significant entity. There are many things happening at the level of the dentate line. Now, as embryology is concerned, the proximal part of the part proximal to the dentate line is derived from the endoderm, whereas distally it is derived from the ectoderm. The epithelium is also different, like how we seen in the endoscopy. The epithelium proximal to the dentate line is formed by simple columnar epithelium, whereas the distal one is formed by the stratified squamous epithelium. And again, as we know that the proximal to the dentate line, it is pain insensate, whereas distally it is painful. Again, as far as malignancies are concerned, the proximal to the dentate line, the adenocarcinomas are seen, whereas distally it is squamous cell carcinoma. So this is the interior aspect as well as musculature of the rectum. Now, coming to the peritoneal coverings, rectum is distinct in that the upper, middle, and lower portion of the rectum has different peritoneal relationships. The upper part of the rectum is covered anteriorly and laterally by the peritoneum, whereas middle part only anteriorly it is covered by peritoneum. Whereas the lower peritoneum, it is subperitoneal, whereas otherwise it is known as extraperitoneal. Now here we can see that the peritoneal reflection is going down to the anterior part of the rectum to the uterine part and the bladder. This is known as the anterior peritoneal reflection, otherwise known as pouch of Douglas. Now, this pouch of anterior peritoneal reflection is roughly corresponding to the 7 to 9 centimeter distance from the anal verge. But again, this depends upon body habitus, depends upon parity, especially in parity in a female. In multiparous, it is seen even up to the level, it is going deep even up to the level of the pelvic floor. Next, coming to the Meso Rectum. Now, Meso Rectum is defined as the fatty tissue envelope in which the vessels, nerves, and nodes of the rectum are embedded. There is a disparity in the volume distribution of Meso Rectum when we take the proximal, mid, and lower rectum. In the proximal rectum, only laterally and posteriorly the Meso Rectum is seen. Anteriorly, it is closely related to the peritoneal reflection. Whereas in the middle, it is encased circumferentially. Again, coming to the lower part of the rectum, the anterior wall of the Meso Rectum is almost fused with the rectal wall, whereas lateral and posterior wall, there is Meso Rectum. Now, the clinical significance of this distribution, volume distribution of Meso Rectum is that, suppose if we take a rectal cancer in the lower part of the anterior rectum, once the rectum is breached, the T stage becomes T4 because early involvement of the anteriorly placed organs like uterus or prostate can happen. Whereas the same lesion, if it is in the mid rectum, it may be still taken as T3 lesion. The second one is during dissection of the distal rectum, what we for a distal rectal malignancy, if the Meso Rectum is gone down onto the rectum, that is, it is a practice that we take the Meso Rectum and we follow it down up to the pelvic floor. Now, once it is done for a distally located tumor of the rectum, there is possibility that the CRM will be positive. So, these theoretical considerations are taken into account when we perform a extra-levator abdominal perineal excision. What is seen in that, what is seen is that in conventional APR, there is increased chance of CRM positivity and tumor perforation because of this volume distribution irregularity of the Meso Rectum. Now coming to the pararectal fascias. Now, this is one of the important slides of my presentation. All the pararectal fascias are actually derivatives of the endopelvic fascia, which are again the parietal peritoneum of the pelvic cavity. Now from posterior to anterior, the pararectal fascias are as follows. Here we can see that the most posterior is the presacral fascia, which is actually adherent to the sacrum. Now this covers the sacral bone and it also encompasses the presacral venous plexus. Just anterior to it is the parietal pelvic fascia, which is actually not seen in this in figure. This is seen more laterally, and this encompasses the autonomic nerves to the pelvic organs. Next is this rectocycle fascia. Now, this rectocycle fascia is otherwise known as the Valdez fascia. It extends from the S4 vertebrae to about 3 to 5 centimeter from the anal verge to the mesorectal fascia. So this actually connects the presacral fascia to the mesorectal fascia and hence gives the support to the rectum. Now, the clinical significance here is that while we're doing a perineal rectal dissection, for the rectum, distal rectum to be completely mobilized, this has to be completely divided. Now, next is the Denonville's fascia or the rectoprostatic fascia, which is seen anteriorly. Now, this is less developed in females. Some literature says that the Denonville's fascia is actually acting like a bib trapezoid bib which falls from the anterior aspect of the rectum. And some literature also says that this denervated fascia is actually a double layered extension of the pelvic peritoneal reflection. Now coming, one more is that is the fascia propria, that is it is otherwise known as the investing fascia of the rectum or the mesorectal fascia. Now, this slide is the most important because the correct plane or the holy plane of surgical dissection in like rectal pelvic surgeries is that the plane of dissection should be between the mesorectal fascia and the parietal pelvic fascia, which I'll be showing in the later slides. Now, what are the clinical significance of this pararectal fascias? First is, if there is violation of the mesorectal fascia, that is, if you're dissecting close to the mesorectal fascia and violating it, this will lead to tumor recurrence. Second is, if on the other hand, if we violate the parietal pelvic fascia, there can be bleeding from the presacral venous plexus. Third is dissection of the rectocycle fascia and its anchoring, like I told, its anchoring rectal wall. This gives better mobilization of the distal rectum. Next is coming to the blood supply. Rectal arteries. Now this figure is actually seen from behind. So here we can see that this is the inferior mesenteric artery. It arises from about 3 to 4 centimeters from the aortal bifurcation. And once it reaches here, there is a division of, finally it continues as the superior rectal artery. So the superior rectal artery gives 1 to 3 branches to the sigmoid column, and then it gives branches to the superior proximal rectum and continues distally after dividing into right and left branches. Now, we all know that the distal extent of the mesorectum is well defined, as we can see in cross-sectional imaging or longitudinal sectional imaging. But the proximal extent of the mesorectum is a controversy. So what is understood is that the superior rectal artery, once it gives off the branches to the sigmoid column, then whatever mesocolon is remaining can be considered as the mesorectum, the proximal extent of the mesorectum. So we can see that the superior rectal artery, it supplies the upper 2/3 of the rectum, and it is derived from the inferior mesenteric artery. The second is the middle rectal artery. Middle rectal artery is the most inconsistent, whether it be its existence, whether it be its origin, or its distribution. In about 40% of patients alone, middle rectal artery is seen. Some studies say that in up to 36 to 57% of patients, only the middle rectal artery is seen. Second is the origin of middle rectal artery is again a variation. Different variations are there. Middle rectal artery, most of the time, about 40%, it arises from the internal iliac artery or inferior gluteal artery. The last is the inferior rectal artery, which supplies the lower rectum, and it arises from the pudendal artery, again from the internal iliac artery. Now, one of the clinical significance of this arterial blood supply to the rectum is that there is a controversy regarding high ligation or low ligation of IMA. As we all know that the high ligation of IMA gives extra nodal yield, whereas it also puts the patient into doubtful injury to the hypogastric nerve. Now, what is said that this can be avoided by ligating the IMA about 1.5 centimeter from the takeoff from the aorta. Low ligation of IMA is when the IMA is ligated distal to the left colic artery takeoff. Now, coming to the rectal veins, otherwise known as hemorrhoidal veins, this follows the pattern similar to that of arteries. Now, the upper 2/3 of the rectum, the drainage is to the IMV, which goes into the portal circulation, whereas lower 1/3 is going into the internal iliac vein, then into the IVC. So the upper 2/3 drains into the portal circulation, whereas distal 1/3 drains into the systemic circulation. The clinical significance here is that the upper and middle rectal tumors, usually the metastases are common in the liver, whereas lung mets are more common in the distal rectal tumors. Coming to the lymphatics, again the proximal 2/3 of the rectum, the IMA nodal chains are draining one, and these drains into the pararectal node, whereas the distal 1/3 are draining into the IMA nodal chains again into the pararectal node, or laterally into the middle rectal nodes, then into the internal iliac vein. Below the dendrite line, like I told earlier, this goes into the ipsilateral inguinal nodes. Next is coming to the innervation. We know that rectum, again being an endodermal derivative, it is supplied by the autonomic nerves, and the sympathetic supplies coming for the upper rectum through the L1, L3 vertebrae level, and this forms the preaortic plexus, and this follows the branches of the IMA and supplies the proximal rectum. The distal rectum is supplied by the presacral plexus, which forms the pelvic plexus and contents at the sacral promontory. And here it is joined by the parasympathetic fibers coming from the S2, S3, S4, otherwise known as the nerva urgentis. And this forms a T-shaped configuration, otherwise known as the wishbone configuration. And it enters the lateral rectal stalk, just inferior to it, and supplies the rectum. This is the inferior hypogastric plexus on the left side, superior hypoglastic plexus, and the sacral S2-3 nerve roots, which forms the nerve, forming the nerva urgentis and joins the inferior hypoglastic plexus. Now there are many clinical significance of this nervous configuration. There can be neural injury while performing a TM. There are 5 different types of injuries that can be seen. One is, like I already told, the inferior mesenteric artery when we are ligating close to the origin. There can be inferior mesenteric plexus problem. Now this can lead to bowel dysfunction. Now the next is the superior hypoglastic plexus at the level of the sacral promontory. This happens while we enter the retrorectal plane. The third is the dissection of the retrorectal space, which may injure the hypogastric nerves. Now, this hypogastric nerves injury can result in bowel and bladder dysfunction. Then at the level of lateral rectal ligament, again the inferior hypoglastic plexus may be injured. And finally, dissecting at the level of Innervation fascia may jeopardize the integrity of the nerves radiating from the hypogastric nerves. So these were the brief surgical anatomy of the rectum, which was relevant to rectal surgery. Now the rectal surgery has been evolved over the past 100 years. The first radical resection for rectal cancer is attributed to Miles, which he did in 1908. This Miles APR was done from 1908 to 1923. And the next important change in the concept of rectal cancer surgery happened after the Hale's description of the total mesorectal excision in 1982. So the first concept was that of Miles. Miles proposed that the rectal cancer spreads longitudinally, both superiorly and inferiorly, and his radicality of the surgery included removal of the tissues as depicted in this figure. Later it was seen that the Hale's concept, which developed in 1982, that the plane which surrounds the mesorectum, the Hale's concept is that the plane which surrounds the mesorectum is actually created by its separate embryological origin. That is, rectum, as we know, that it's a part of the gut, and it is derived separately than what is seen in the surrounding paired viscera or the parietus. That is, the whole rectum and mesorectum has the same embryological origin and are considered as one lymphovascular entity, whereas the surrounding parietus is a separate entity. This forms the principles of total mesorectal excision. It is defined as the excision of the rectum with mesorectum with an intact visceral facial envelope with the en bloc resection of the lymph nodes along the superior rectal vessels. Now, this should also have proximal, distal, and circumferential margins as negative. Now, previously when I showed I've shown that there is the different fascias of the pararectal space. Now, this is actually the plane of dissection, otherwise known as the holy plane of rectal surgery. It is between the investing layer of investing fascia of the rectum, otherwise known as the fascia propria, and the parietal pelvic fascia. So, in most of the GI surgeries, it is about pursuing the planes between the embryological separate lymphovascular entities. So what is believed that rectal cancer initially tend to maintain within the embryological hindgut envelope. So rectum, as other gut derivatives, it was developing primarily as an extra abdominal structure in the developing fetus, and these organs get secondly retroperitonealized, and it is later plastered onto the developing pelvis. So these rectum and the mesorectum retain the midline lymphovascular entity, and this is separate from those of the surrounding paired organs and the parietus. Now, this adhesion, this plastering between the rectum and mesorectum towards the retroperitoneum is by a web of loose areolar tissue. Now, this is actually what is recognized by the surgeons as the surgical plane. So, to summarize, the surgical anatomy of the rectum, the important aspects to be seen are, one is the plane of the different fascias of the pararectum. Out of that, the important one is the plane between the fascia propria and that of the parietal pelvic fascia, which is now recognized as the holy plane of rectal dissection. Then we have to know the arterial anatomy and venous anatomy. Then regarding the different the two different concepts which have evolved. That's all.
Arun.
Sir. Yes, sir.
No, I thought you would dwell a bit more in detail regarding the perineal anatomy also, because your topic was anatomy pertaining to rectum in relation to APR. So when you talk about APR, it's all about perineum, because it's a low rectal cancer. So I thought you would describe a bit more regarding the muscles of the pelvic floor, their relations, their anatomy, all those kind of things. Anyway,
Yes.
So, and what is the importance of defining the upper margin of rectum? And what is important? Is there an importance of defining the lower margin of rectum? You said there is a difference between the anatomist, the radiologist, and the surgeon regarding the definitions of upper and lower limit. What is the oncological importance?
The one importance is that regarding neoadjuvant treatment, if suppose the MRI wise the lesion is in the around the rectosigmoid junction,
Okay.
if we denote it as a rectal cancer, say suppose the lesion is in the at the level of uppermost part of the rectum, and if the radiologist define it by the actually, sir, in MRI, the definition of the proximal limit of the rectum is at the level of sigmoid takeoff. So,
Okay.
when there is a difference in definition, there can be we may subject the patient unnecessarily to the adjunct means neoadjuvant radiation therapy, even if it is a rectosigmoid or sigmoid lesions.
Okay.
That is one importance.
Okay. Anybody else want to contribute? Harish.
Sir, mainly for the margins, the vascularity, so we need to know the margin. We need to take adequate margin.
No, I'm talking about the proximal limit. Are you worried about the margins when you're talking about proximal margin, proximal limit?
Proximal limit, mainly vascularity, sir. Since we will tie the IMA, the vascularity of the proximal bone.
No, it's not like that. See, you are very concerned about the proximal margin because the natural history is different. Natural history of rectal cancer is different from the natural history of colon cancer. So when it's colonic cancer, you're concerned about the systemic recurrence or systemic metastasis.
And rectum,
but when it comes to rectum, you are concerned about the local recurrences. So your natural history of rectum is different from the natural history of colon. And just because of that, the management is also different. As Arun said, you have to have radiation as part of your treatment. So defining an upper limit is very important because natural history is different. And based on that natural history, your treatment protocols will also change.
Yes, sir.
Second point is that if you wrongly take a sigmoid as rectum, you would be unnecessarily giving radiation. It's not like that you would be unnecessarily giving radiation, you would be giving radiation to a lot of small bowel, which increases the toxicity in the long term. So that is why you have to define the upper limit very clearly. But still you will have some amount of subjectivity because that 15 centimeter can vary depending upon the measurements you take, or even the sacral promontory can, the lie of a redundant sigmoid, it can change the position. But still the point is that you have to define the upper limit very clearly. But the lower limit is not that very much important because if it's 1 centimeter, 2 centimeter, 3 centimeter, if it's adenocarcinoma, you treat it as rectal cancer. If it is squamous, you treat it as anal canal cancer. So it's the histology that matters when you come to lower limit. But when it comes to upper limit, it is the location that matters. Got the point?
Yes, sir.
Madhu, I have a slightly.
Yeah, I know that you will always differ.
I'm trying. So my two things are online. That happens. Okay.